So we always start our lectures with financial disclosures. I have none, except that I have been a CASA supporter for more than 20 years. That's our women's and children abuse shelter here in Pinellas County. I have also worked with the Springs over in Hillsborough County, our sister organization over there. There we go. I always try to list the objectives for our sessions in the morning. We're going to define domestic violence. I want to help you recognize the prevalence of domestic violence. What is the impact on health care? Discuss the signs and symptoms that should alert us as physicians or healthcare practitioners to the possibility of domestic violence. And I want to describe some methods to screen for domestic violence. We should be able to identify community resources in our own community and for both our survivors and for the perpetrators of domestic violence. And we want to recognize the signs of depression and the risk of substance abuse associated with domestic violence. What have we learned in 25 years? I first gave this lecture in 1994. Those of you who were practicing then remember that it was all over the news when tragically, a woman and her boyfriend then were murdered out in California, and it triggered a big national debate on domestic violence. And so maybe something positive did come out of that terrible tragedy. My own group asked me to start speaking about this at Tampa General, and I've since given over 100 lectures on this topic. And I still receive a lot of positive feedback, not only from our colleagues, not only from the doctors who attend, but also from our nurses. A lot of our staffs and even family members have been subjected to this. So it's never far from my mind, and I hope maybe this will be a little bit closer to the top of your minds. Domestic violence, my definition, is a pattern of assaultive and coercive behaviors aimed at establishing control over another person. There are different methods that the perpetrators will use. It's in some ways easiest to see inflicted physical injury, and we have a wonderful lecture coming up following mine about the physical effects of trauma and domestic violence on patterns. There's also the psychological abuse, which, as we're coming to recognize, is more pervasive and ongoing, and sometimes much more difficult to recognize. Sexual assault, we're all very familiar with. We've all done evaluations after sexual assaults. The social isolation, stalking, deprivation or neglect of an intimate partner, intimidation, and threats. Those are all patterns that perpetrators use to control their victims. And when we first started talking about domestic violence, we always used the word victim. Now we've come to recognize it's more important to use the word survivor, because these individuals have been through episodes that I hope none of you have been through, but we need to recognize their courage in getting through these times, and a survivor is a better description. What are the forms? Intimate partner violence includes the family of domestic violence, includes child abuse and elder abuse. Child abuse was the first form recognized. It was recognized in the 70s. One of my professors, Dr. Patricia Fleener, was very active in getting the recognition of child abuse brought to the forefront in healthcare. And she was a pediatrician in Indianapolis, Indiana. And elder abuse came to be recognized later, but living in the Sunshine State, or as Don sometimes refers to it as God's waiting room, we have to be aware of elder abuse also. In the state of Florida, which I'm proud to say we have a budget that is in the black, we only allow $37 for each domestic child abuse case that's called into the state. But the amount of dollars we have available to investigate elder abuse is more like $9. So when you see those numbers, I think it puts a lot of the burden back on us to make sure that we have as much information as possible to help state agencies help these individuals. Intimate partner violence is those abusive behaviors that are perpetrated by someone who was, is, or wishes to be in an intimate relationship. Partner violence has been pretty well recognized, but dating violence has not been recognized as much. However, when we did a study over at USF, we found a very high percentage of the individuals responded that they had been victimized by dating violence. And some of you have children that are in college age or have had. Some of you will be having children in that age group. And it's important that we recognize that we need to educate our families about this. What's the incidence? Sexual violence against women. 18% of women in the United States, this is US data, have been raped. 51% by an intimate partner, 40% by acquaintance. 13% report sexual coercion, and 79% of rape victims experienced their first rape by age 25, and 42% of these were before age 18. So since I practice at a children's hospital, those numbers are pretty daunting to me. How many of you knew that these numbers were so huge? 3, yeah. I'd say that's about right. Doctors, by and large, are not aware how big these numbers are or how young the individuals are. Men, I don't ever want to leave men out of the equation because men are also victimized by perpetrators who attempt to control and coerce them. But the numbers are much smaller. And there are also many social stigmas which prohibit men from coming forward and complaining of these types of attacks. 1.4% of the men have been raped, 52% by acquaintance, 15% by stranger, 5% have had forced penetration, and 20% of male rape victims experienced their first rape by age 11. I mean, that's just pretty hard to stomach at 8 o'clock in the morning, I know. But maybe we're finally starting to talk about it in a little more open fashion. Certainly there's been a lot of spotlight being shown on people from California and New York, and maybe that will precipitate the rest of us to recognize we need to talk about it more. So the terminology, domestic violence, is now more correctly referred to as intimate partner violence, and the victim of violence should more correctly be referred to as a survivor. I hope that meets with, is Melissa here yet? We're going to hear from a young person who's been through a lot of this. Total intimate partner violence in the United States in women, it's 35% of all U.S. women experience intimate partner violence in lifetime. My immediate family is 62 people, half of which are women, and I know for sure 2 of them have been experienced intimate partner violence. I'm sure if you are in good contact with your family members, you have some experience of that as well. And these go across all lines, right? There used to be a thought that this only happened to poor people, this only happened to uneducated people, this only happened to certain people of different religious faiths or non-religious faiths. And what we've found is that it crosses all those barriers. It crosses educational barriers, it crosses financial barriers, and faith-based barriers. 10% have been raped by an intimate partner, 10% have been stalked, 25% experience severe physical trauma, 48% experience psychological aggression. It's probably even higher than that. And 1 in 3 victims experience multiple forms of IPV. In men, 28% of all U.S. men experience IPV over a lifetime. That's a huge number. And I think that for us to even come up with that number, it took a lot of courage to get people to come forward. 14% experienced severe physical violence, and 48% experienced psychological aggression. What is the national economic burden? One of the ways we quantify the quality of our care is we look at what the cost is, and overall the cost is estimated to be over $5.8 billion annually, and more than $4 billion for direct health care services. So when we see those numbers start to come down, maybe then we're making a difference, because that's really my message today is, in 20 years, have we made any difference? Do we have any more awareness? Do we have any more recognition? As more and more women come into the healthcare profession, I hope that we are becoming more attuned to this. I think the men did a good job, a great job. We wouldn't have the healthcare system we have if it hadn't been for our male leaders in the past, regardless of what our former First Lady said yesterday. I have a lot of respect for what the men have done for our healthcare system. But I do think women bring an added sensitivity to our patients, and being the leaders that we can be, we can model that sensitivity, and hopefully our colleagues will pick up on that as well. What are the financial consequences for victims? We've all seen this. They're more likely to be homeless. They're more likely to have few financial resources. They have an increased risk of incarceration, having had jail time, and loss of employment is a big problem, because if you can't have a paycheck, you know, how are you going to support yourself and get out of a very difficult situation? So I always ask, did you see any patients this week who have experienced domestic violence? Okay, Phil, I know you're very tuned into this. I know you're very tuned into this. Probably. Now, do you know which ones? That's a harder question, okay? So maybe when you go back to Kentucky and home, you'll think about these. 10% of all primary clinicians report that they have never seen a victim of domestic violence. Wow, that's a big number. I don't know where they practice, but it's not St. Petersburg. 55% of all PCPs report that they have never recognized a perpetrator of domestic violence. And that can be more difficult. I do think it's hard for us as sensitive, caring individuals, compassionate individuals, to recognize people who have a private face and a public face, okay? What we see as their public face very often isn't what is seen at home. And so I think that number is probably correct. Patients report 11 visits before anyone asks if they're safe at home. Now, we've put on our forms, gosh, I think in the mid-90s, Dr. Petty, that it's part of our screening questions, you know, do you feel safe at home? Emergency patients, however, reported 17 visits before they were asked if they were safe at home. And that's what prompted us to put it on our questionnaire. And our triage nurses are very active in asking this. However, I have to say that we're still falling a little short. We recently did a chart review, and we showed that there were 7 visits before the patient's chart was actually documented that someone had asked that. Some improvement, but not as good as I'd like to see. What should alert the clinician to the possibility of violence or abuse? Well, of course, suspicious injuries in various stages of healing, just like we look for victims of child abuse. You know, if we find an old rib fracture in a patient who's in for a spiral fracture of the femur, they're very suspicious that individual is suffering from child abuse. Some chronic conditions. I think one of the most common one of the most common complaints is pelvic pain. I'm sure our OBGYN doctors that are here have a lot of experience, and the ACOG was very instrumental in getting the lectures started on domestic violence. Some chronic abdominal pains and some chronic chest pains will also be associated with this condition. Some acute illnesses or conditions. A poor response to treatment should also be kind of a trigger to make you think, could there be something else going on? And some health behaviors, and of course social issues. I remember very well when I was at Tampa General, and I always had my residents see the patients first, and then they'd present to us, and we'd go see the patient individually. And this 35-year-old woman had come in with abdominal pain, and nothing the resident had told me made any sense. It didn't go along with ulcers, it didn't go along with pancreatitis, it didn't go along with irritable bowel syndrome. And I said, well, let's just go see the patient. And when I went in to see her, I saw a very anxious person, and I said, is there any chance that someone at home is not treating you with respect? She immediately started crying, and of course my resident was just terrified. I said, well, I think it's better that we talk about it than we ignore it, okay? and that we don't do tests that aren't going to find any organic pathology. It's better to bring it up early in the care, not late. And I hope we continue to give that consideration to our patients. Suspicious injuries, gunshot wounds and stabbings, of course. Multiple wounds, again, is in various stages of healing. Tympanic rupture of the membrane, rupture of the tympanic membrane. Facial fractures, loose or broken teeth, burns, suspicious pattern of bruising, strangle marks on the neck, bite marks, fingertip marks on extremities or thighs, frequent falls with sprains or fractures, the history of she's clumsy, serious head injuries, especially if it's repetitive, and obviously a history that's inconsistent with the injury. They just fell down, but they've got multiple fractures. That's probably not the correct story. Acute conditions, frequent infections, particularly sexually transmitted infections, urinary tract infections, recurrent urinary tract infections, pregnancy or unplanned pregnancy. That's particularly a dangerous time for individuals who are in an unsafe environment. Placenta abruption, preterm labor, short interval between pregnancies, and of course self-harm, either suicide attempts or cutting of the skin in an attempt to improve their mental status. Chronic conditions, chronic pelvic pain, irritable bowel syndrome, headaches, sleep disturbances, depression, anxiety disorders, PTSD, substance use disorders, eating disorders. Poor response to treatment may indicate a patient unable to obtain or take the medication. And you know, that pretty much looks like your day sheet, doesn't it, those of you who do primary care? It looks like mine, except I'd have to add in respiratory complaints. We see about 30% of our patients have respiratory complaints. Health behaviors. A delay in seeking care is always a warning sign to me. Overuse of services with vague complaints, distress out of proportion to the injury or condition, fearfulness of the examination, poor adherence or compliance with treatment plan. Substance use during pregnancy is a big concern to us, not only for the individual but for the baby. Disordered eating, risky sexual behavior, and particularly a partner who won't leave the patient alone with us or answers questions for the patient is kind of a warning sign for me. So when we suspect abuse, what do? In my experience, these types of symptoms can be made worse or caused by stress. So I ask the patient, are there any sources of stress in your life? Or I may say, this type of injury is sometimes caused by other people's actions. Is somebody hurting you? Is anyone hurting you? And this type of behavior sometimes suggests problems with safety in a relationship. Is anybody frightening you, is my question. And I try to make it general. I try to make sure that the patient knows we're not judging them. This is a very difficult time in their lives, and just as you wouldn't judge someone who has developed diabetes or angina, you don't want to judge a patient who is in a dangerous relationship. So my best question, and the question I've used for 25 years, is because domestic violence is so common, I now ask all my patients if they feel safe at home. And I think that is one of those ubiquitous statements that doesn't pass any judgment, and I get a lot of positive feedback from that. You want to be direct, but don't force or pressure for disclosure. Just asking about IPV can be helpful. You don't know when that patient's going to be ready to seek help, but it may be their first experience with somebody who thought to take the time to express their concern. Patients will rarely disclose a history of abuse spontaneously. That's been my experience. Be prepared to ask at a later date. And if he or she suspected abuse, we don't want to confront or challenge these individuals. We can express concern. Sometimes we can describe the resources. I have business cards from our abuse counseling line that are available, and we try to arrange for follow-up. And you can document your concern on your chart without concern for increased liability. This is so common, I think it's important to be in our charting. What's the response to disclosure? Well, you want to validate the patient's experience. You want to listen with empathy, acknowledge the complexity of the issue. We want to respect the unique concerns of that individual and their decisions. We want to put the patient-identified needs first. After all, they've not got very much control over their home situation. The last thing we want to do is take control of the situation in their health care as well. Help the patient identify where he or she can have control of their situation and address social and psychological needs of the patient, provide some encouragement to them. The safety assessment is probably our best way of helping these patients, but we can ask them if they're afraid to go home, if they have a safe place to go. I usually ask if their partner's in the waiting room. I ask if anyone has threatened to kill them, or their children or their pets. Sometimes that's one of the first clues that we're going to have more violence or more danger to this individual. Has there been an increase in the severity or frequency of abuse? Are there weapons present? I know there's a big controversy about asking about weaponry in the state of Florida. I don't know about your individual states, but from a safety point of view, I feel confident in asking that question. Is there a history of drugs or alcohol? And I think we need to remember that women in the United States are much more likely to be murdered when leaving a relationship. So it can't be our decision when they leave. It has to be that individual's decision. What is our response? We can offer a private place to make a phone call, right? We can provide community resources, shelter information, hotline numbers. I'll give you those. They're in your handout or your slide presentation. Referrals for additional care, including psychological support. And we want to make a follow-up appointment before the patient leaves the exam room. I want to emphasize the importance to that individual of disclosure and reinforce that anything they say to us is kept confidential. What are the components of documentation? Again, a detailed description of the patient's disclosure, detailed description of their injuries, include photographs and drawings if possible. Again, I always inform the patient that those photographs will not be used except with their permission. We'll record the resources provided, assessment of the safety of the individual, and document our follow-up plan. What are the social issues to consider? Abusive towards children, neglectful or abusive towards pets. Sad to say that this country gets more upset about abusing pets than children. And I am an animal lover, but we have 6 children and 14 grandchildren, so I have to say that the children should be weighing higher than the pets. Isolation of the individual, restricted access to medical care. If they can't get to our office, they can't get help. Estrangement for family and friends. What is the economic dependence on the abuser? Do they have job insecurity, or are they afraid of losing their job? Work or school absenteeism. Homelessness has a high correlation with domestic violence. Prostitution and incarceration. Under prostitution, I will mention the sexual trade concerns we have in the United States. We're just now starting to uncover these, and these are not individuals that physicians are really trained to deal with. And if you suspect that there's someone who's been coerced into a forced situation, I really feel that your best bet is going to be to contact law enforcement. Because you have to keep yourself and your staff safe. LGBT issues, we used to think that it occurred in the same proportions as in heterosexual relationships. However, now that we have provided some support to this community, we're finding that men living with male partners experience more intimate partner violence than men living with female partners. And women living with female partners experience less interpersonal intimate partner violence than women living with male partners. So there is some difference in that community, and as clinicians we need to be aware of that. The concerns, I think, are legitimate in that there will be fewer services available, and because it is a very small part of our population, clinicians are less comfortable asking direct questions. Now, I know there's a LGBT conference during this conference, so hopefully you'll get some tips on working with these patients. Here are some YouTubes that you may want to watch. I think they had a little insight. And then what happens when children witness intimate partner violence? Because as a pediatric emergency doctor, that's a concern I have. They are 2 to 4 times more likely to have behavioral issues. And we know behavioral issues cause problems in school cause social problems, and can lead to a whole cascade of struggling with success. Depression and anxiety is increased. They may have increased risk of attempting suicide. They have increased risk of substance abuse. They may participate in risky sexual behavior. They may exhibit episodes of violence towards their peers. They may actually commit sexual assault. There's an increased incidence of runaways. And child abuse occurs in about half of the households where intimate partner violence is occurring. So with all those concerns, I think it's well worth 45 minutes of your time to listen to me and the next couple of speakers. I think that this is huge when we think about what kind of world we want to leave behind, what our legacy will be. But the bad news is that 1/2 of all children who are abused become abusers. The better news is that half do not. Half of them learn the lesson that this is not how they want to learn their lives. And I think that gives me hope for the future, okay? I hope it gives you hope too. What are the reporting laws? It's mandatory reporting for children who are victims of intimate partner violence or domestic violence, elderly and vulnerable adults, and that's the abuse line, 1-800-96-ABUSE. As of October 12th, which is the closest we have the data, it's now a felony if a clinician does not report suspected child abuse. So we want to be sure we're complying with the law. It's mandatory reporting for life-threatening injuries such as gunshot wounds and stabbings, and you report that to your local sheriff or police department. But it is not mandatory in our state to report domestic violence. What do we do about dating violence in teenagers? Well, if they're under the age, that still counts as child abuse, right? And what about children who witness domestic violence in the home? Screening guidelines. The Institute of Medicine recommends screening and counseling for all women and adolescent children for interpersonal and domestic violence in culturally sensitive and supportive manner. That was 2011. However, they found, when they studied this, we found insufficient data to recommend for or against routine screening. That was in 2004. ACOG recommends physicians screen all partners. ACEP, my college, recommends that physicians be alert for risk factors as well as signs of family violence with patient encounter. And the American Academy of Pediatrics recommends that questioned family about family violence should be part of any anticipatory guidance. So as of 2012, the Affordable Care Act ensured that select U.S. health plans now cover annual screening and counseling for lifetime exposure to domestic and interpersonal violence as core women's preventive health benefit. As I'm sure you're all aware, these regulations are in flux, and we have to be aware of the changes that occur out of the regulations in Washington. What is the evidence for screening? There is a high prevalence, and screening can provide benefits for individuals. The con, which was reported in JAMA in 2012, there's no beneficial health outcomes been documented for computerized screening. Excuse me. And we're uncertain whether there's a benefit to the partner violence screening that is personally provided by the women's established primary care provider. Primary outcome was quality of life measured at 1 year. So I don't know if the time frame wasn't long enough, if we need to go out further to see if this actually makes a difference, but what I would say is that screening for it will prevent you from doing some unnecessary tests and unproductive care for the patient. So how are the patients asked? You know, what was the method for screening? Was it a computerized question? Was it a written form? Was it part of intake history with admission to a hospital? And was it an interview with a nurse or other healthcare provider? The types of questions or screening tools used. You know, these are, well, I'll show you these. So partner screen, number 1, have you been punched, hit, or otherwise hurt by someone? Do you feel safe? Is there a partner from a previous relationship who is making you feel unsafe now? Are they being stalked? Hurt, insult, threatened, or screamed at. This is the HITS screening. How often does your partner physically hurt you, insult or talk down to you, threaten you or with harm, or scream or curse at you? Assessing a history of abuse. Have you ever been in a relationship which your partner frightened or hurt you? When you were a child or teen, did anyone ever physically hurt you? When you were a child or a teen, did anyone force you to do something sexual you did not wish to? And when you were younger, did anyone tell you you were worthless or unwanted? As an adult, have you ever been physically hurt or forced to do something sexual that you didn't want to? And the screening for ongoing abuse, how do you settle disagreements in your relationship? I think that's a very telling question. Do you feel safe in your current relationship? Is there someone from a previous relationship who's making you feel unsafe now? Is anyone forcing you to do something sexual you don't want to? And is anyone following you or harassing you in the community? Screening for perpetrators. This is a little more delicate, I think, but all people argue. How do you and your partner handle disagreements or fights? Do your disagreements or fights ever become physical? Have you ever used any kind of physical force against your partner? Has your partner ever pushed, grabbed, slapped, choked, or hit you, or have you done that to them? Sometimes by asking if they've been injured first, you'll get a more accurate answer from them. And has your partner ever forced you to have sex or perform acts which you did not wish to, or have you done that to her or him? Intimate partner violence and mental health. This is a really growing issue with intimate partner violence because there is an increased risk of depression, increased risk of post-traumatic stress disorder, and an increased risk of substance abuse. The risk of depression is 2 times. The risk of postpartum depression is twice, and post-traumatic stress disorder may be 6 times higher than in the normal population or in the unharmed population. They have an increased risk of self-harm, eating disorders. Again, substance abuse may be as high as 6 times in the unabused population, and they may have anxiety and sleep disorders as well. So this is kind of my acronym for remembering these questions in your exam. Remember to ask routinely, ask direct questions, document your findings, assess the patient's safety, and respond, review options, and refer. This is another one of my mentors, Monty Roberts, the great horse whisperer. Those of you who know me well know that if I hadn't been a physician, I would have been an animal behaviorist. No one was born in this world to say, yes, you must, or I will hurt you, to another human or any animal. I think that's good advice for all of us. I've listed some community resources which are available to you nationally and then specifically for Florida. NoMore.org was started with the NFL's assistance. They still struggle with some of their individual players. More resources at, I've supported Physicians for a Violence-Free organization since that started in the 90s. And the Women's Health section is also a good resource for you. Reality check, though, guys and ladies. Physicians cannot be responsible for rectifying all the violence in our society. We can, however, be agents for change and model better behavior. We can accurately assess, document, and diagnose domestic violence survivors. There's some references for you who want to look into this further. And these are some books that may be of interest to you and may be of interest to some of your staff: When Men Batter Women, Guide for Domestic Violence for Physicians, Portrait of a Child in a Violent Home, The Gift of Fear, Man Who Listens to Horses by Monty Roberts, and my good friend Dr. Susan Harrison in Tallahassee, who helped me with some of these slides. If not you, who? If not now, when? And if not here, where? And finally, my pearl. I try to end with a pearl. Violence is the last refuge of the incompetent. So thank you for your kind attention, and if you have questions, I'll make myself available now for
questions? Or, do you have some questions?
Do you have questions on
Back-
the webcast?
back in the back.
Why don't we check the webcast first, and then we'll open it up to the group.
Wait a second.
Out of respect for our sergeant partners.
Right.
So we just want to give her that. There you go. Well, go ahead, Dr. Queen. Go ahead, Dr. Queen.
Doctor?
I really enjoyed this talk. This is something that's kind of been part of my practice as a surgical oncologist. I ask my women, are they safe at home? Give me some insight on how to deal with a teenager that is creating the violence, because I had a patient, a lovely labor delivery nurse battling breast cancer, whose 13-year-old killed his father and his brother while she was at work one night. And the big question in Texas, are there guns in the home? Get them out. And who can you talk to? But help me battle this issue, because I had a premonition this was going to be something that was going to blow up, and it did. What can we do with a teenager in the home that has violent tendencies, and parents are aware and capable, they think, of dealing with this
Right.
patient?
Right. Well, what a terrible tragedy. It's a very difficult situation, and we're seeing it, sadly, in younger and younger children. We're seeing oppositional defiance disorder in children as young as 6, 8. Kids that in the past we thought you could just send them to their room or put them in a corner. The easy answers aren't there so much anymore. An engaged family helps a lot. Sometimes the parents who think they can handle it, what they really need is more support from grandparents, aunts and uncles, need a bigger community around that individual. And as a clinician, what I really would caution you to do is not take the blame on yourself, okay? This is not something you could have had a crystal ball for. We've all seen violent teenagers and preteens, and there's no 100% predictability, even with the great technology we have, that would have let you know that this was in the making, okay? Now, picking up the pieces, I think you're going to be more supportive for your patients that you see going forward, and maybe a little more aware that this type of violence can escalate. So I guess what I would say is the way to handle it is to be even more a vehicle for information and for delivering information to your community. Be even more a model of supporting the resources that are available, like our wonderful CASA here in St. Petersburg and Springs over in Tampa. And maybe it's time for you to get out and start lecturing. You know, Grandma here is getting old. We need to have younger doctors and younger people speaking up and getting out and active in our community. I don't think that any one person could have stopped that tragedy. Okay, that's my best answer for you. Anyone else?
Yeah, I got one right.
Yes.
This topic is home for me. And the reason why is, growing up, I was constantly told that I was not worth the air that I breathe. So it's personal for me. That being said, this affects minorities. And in a minority population, it is not discussed one bit. I can vividly recount the days when I was on the ground and my father was kicking me on the ground. My mom sat there and watched. She couldn't do anything. She couldn't reach out to any of the family members, anything like that. What can you say in terms of giving advice to the folks here when it comes to minorities
Well,
and cultures?
were you in this country at that time, Ajoy?
Huh?
Were you in this country at that time?
Yeah.
You were in this country. Fortunately, we started recognizing now, almost 50 years ago, that children have rights, and that as adults, the least of our responsibility is to ensure the safety of our children. And we weren't as good at doing that 50 years ago, 40 years ago in your case. But I hope we're getting better at it. I hope that you, and I know you personally, have used your lifetime experiences to make you into the compassionate and effective clinician you are. So even though you experienced tragedy in your past, you have been able to incorporate that into the character and the substance of the person that you are. And like I say when I have given this, and the data confirms it, only half of the people who see abuse will perpetuate it. Half of them do not. This is, you know, we used to talk about substance abuse and family abuse, and they were, you know, it was the same epidemic. They weren't the same epidemic. And there may be some tendency in an individual, but it's a learned behavior. And any behavior we can learn, we can relearn or unlearn or learn a better response. So I think I would be encouraged by the fact that you were able to get beyond this. And I think that you have been supportive of your mother and recognized that her weakness wasn't on your behalf, it was only on her own behalf, and that her character, I'm sure, has developed over the years.
Yeah, I just want to kind of add to that. It's very prevalent in minority communities. Those of you who are staying here and enjoying wonderful St. Pete, Tampa's number 3 for human trafficking. And that shocked us all when we heard that. Mm-hmm. It's real.
Yeah.
Thank you.
Yeah. Thank you for your comment. Yes,
Okay.
Doctor. Talk to the box. It's okay.
Going back to the very unruly, unmanageable child, are there any studies that shows that if you remove them from the home and use military schools, sheriff ranches, etc., to do any good to turn these children around? And why doesn't the Department of Children and Families, the State Department, be more active at removing these children from that desperate situation?
Right.
They try to keep the child in too long.
That's a great question, Doctor, and you clearly have a lot of insight into this. That is another organization my husband and I support, are the sheriff's ranches, because sometimes these kids need to be completely in a different environment, in a very regulated environment. I don't know of any studies that support that, but anecdotally, I have seen many, many wonderful cases of children who were just headed down the wrong path, already cutting themselves, you know, before they were even 13. And they were able to see some value in being brought into that group as a whole. Another reason I speak so highly of Monty Roberts is he and his wife, in addition to the 3 children they raised, have raised 46 foster children. And these were largely children that were brought to his ranch out in Solvang, California by the police department and the sheriff department, because these kids were going down the wrong path, stealing things at the 7-Eleven or whatever. And he not only gave them a safe environment, but he gave them a job to do. And he praised them for the jobs they did. Now, it might have been digging a hole over here and putting the dirt over there, but he praised them for doing that work. And when they did the work, he brought them into his herd, his family herd. And when he brought them into that herd, they felt protected and safe, and they learned to want to participate in that family and to contribute to that family. And that's what the sheriff's ranches do as well. But when you can take in, I think the number was 46 foster children, and 44 of them stayed out of jail and are productive members of society. Now, that's not a study, but that's pretty good numbers. I wish 44 times out of 46 I was successful in my interventions. I hope I'm successful in the majority of them, but that's huge numbers. So that is a very good point. Great question. Somebody else? Oh, I'm sorry.
One last question so we can stay on time.
It's all right, Dr. Pitt. I'll meet with her later, I promise.
Just one last comment.
Please.
The problem with the physician,
It's for the webcast.
For the cyber
the
doctor.
problem with the physician in the office in engaging in these
Situations.
screening procedures and so forth, and it's been mentioned in the literature, it opens a, quote, Pandora's box. And before you know it, your day is gone and your week is gone if you get into this advocacy situation. I just thought I would ask you to comment on that.
Right. And, you know, it's a challenge for any patient, right, Doc? Nowadays, we have so many time constraints. What I would encourage you to do is help develop your staff as well as possible. Just as Dr. DePetti was clear to refer to our staff here at the SMA is phenomenal. When there's something we can't do or we have to move on to the next case, we have to have educated our staff in such a significant way that they can help pick that time up. And that's the best answer I can get.
So, actually,
You got time?
I'm Dr. Jimenez, I'm a psychiatrist. I am from Maryland, Montgomery County, and I'm very proud of what we do in our state, where we actually have a DV week, Domestic Violence Week,
Wow.
where there's a lot of promotion of people, you know, our services, the county services. So once that's out, we expect a lot of calls, and we get a lot of calls, and we reassure our clients that their identity will not be put out there unless they have, they want to. So I think asking or advocating, as physicians advocating for a domestic violence week where we receive calls from anonymous callers would be one way of responding to it. Thank you.
Oh, very good. Thank you for your comments.
Paula,
And
can I-
thank you for your work. That's tremendous that you have a whole week devoted to it. That's fantastic.
Paul, I know we're going a little bit over, but this is really, really important. Hopefully, the other speakers will readjust.
So,
But
forgive me.
what about the provider? I personally, I have a personal story, but it's not a long story. I do very minimal primary care, and it's in a
Right, I know.
resident-driven indigent care clinic. And we see these individuals, predominantly women, but men too. It affects the provider.
It does.
What about us?
So what about us is a great question. You know, I always say I spent the first half of my career taking care of, well, overall, close to 140,000 patients. If you'll look at that number, it's a big number.
Wow.
But the last 10 years I've spent trying to take care of the providers. And we as physicians and healthcare providers do need an opportunity to decompress. Coming to meetings like this is so important. I am so grateful of all of you taking time out of your practice to come back. Don used to say it's like sharpening your saw. You can cut a lot more trees if your saw is sharp, right? So come to the meetings, spend time with your colleagues, take time to decompress your staff after these traumatic interventions. And one of my favorite questions is, now, is there anything else we could have done? Does anybody else have a suggestion? And that way, when my staff goes home, they know that they were listened to and that we tried to do everything we could for that individual. So I'll recommend that to you.